Genetics of connective tissue disorders. So the objectives of this lecture is going to be to understand the function of connective tissue, to list the inheritance patterns for Marfan syndrome, Ehlers-Danlos types 1 and 4, as well as Loeys-Dietz, and to identify the clinical criteria of Marfan syndrome. There are a number of components to connective tissue. Connective tissue is essential in holding tissues together. The extracellular matrix consists of many components, and one of the most important parts is collagen. There are 25 currently known genes that code for different types of collagen. In addition to collagen, there are a number of other structural proteins woven into this microfibrillar array to provide the basic meshwork for the connective tissue matrix. Abnormalities in any of the components of connective tissue will result in weakness of the tissue. While all tissues have connective tissue, tissues most affected by abnormalities in connective tissue gene abnormalities include skin, bone, blood vessels, and joints. So let's talk about the clinical diagnosis of a connective tissue disorder. One of the most common features that's abnormal is an increased flexibility at the joints. And one method to determine the flexibility of the joints is something known as the Beighton score. So I'm going to go over the Beighton score here, and it's a point system. There's 9 points. You get 1 for hyperextension of the elbows, 1 for the right, 1 for the left. Being able to pull the thumb down to the side of the wrist, again, 1 for right, 1 for left, so 2, 4, 6. Pull down the hand all the way. I usually don't do the foot, but hyperextension at the knee. So you get 1 point for the right or left. You could do this or this, but let's just talk about this one. And then finally, you get a point for bending over and being able to touch the palms to the floor. So 2, 4, 6, 8, 9. 9 points. The difficulty with this scoring, and it's considered positive if it's over 5 points. But the difficulty with this scoring is that young children are often very flexible, and it's not unusual for them to have a Beighton score of 6 or greater. And older individuals often have damage to their joints and may have a negative Beighton score because they had to have bilateral knee replacement or other types of surgeries. So the first one I want to talk about is Ehlers-Danlos type 1 or classic Ehlers-Danlos syndrome. One of the key features is a doughy feeling to the skin and it being super flexible. So when you feel the skin of a patient that had a classic Ehlers-Danlos syndrome, it's very doughy, and you can see how stretchable it is. The skin is also fragile, and patients often require sutures even with minor trauma. So often little kids, they have to wear helmets and chin cups under their chin. They will, they have a fall and rip it open. So they need stitches all the time, even with minor trauma. They have, and these stitches have to be done in more than one layer because they don't hold together very well because of the connective tissue. They bruise easily because any kind of fall or any kind of trauma to the skin results in bleeding in between the tissues. And one of the major features is hyperpigmentation of the knee. And this is called the papyrus scar, or like a cigarette paper kind of scar here on the knee. There's an increased risk for mitral valve prolapse and aortic root dilatation, but far less common than the other connective tissue disorders we're going to talk about in a second. So to make a clinical diagnosis of Ehlers-Danlos type 1 or EDS type 1, greater than 6 points on the Beighton score or joint hypermobility, widening atrophic scars when they need stitches, it doesn't even heal very well, skin hyperextensibility, 50 to 90% who fulfill the criteria for EDS classic. Again, when I say clinical criteria, everything used to be a clinical criteria, and then we found the genes. But 50 to 90% of patients who fulfill the clinical diagnosis of Ehlers-Danlos classic will have a mutation of either collagen 5A1 or 5A2. This is a pretty big range, 50 to 90%. There is likely another gene that we don't know about today as of the time that I'm, taping this lecture. Medical complications of EDS type 1 include recurrent joint dislocations, recurrent ankle sprains, recurrent need for sutures, poor wound healing, and a mild increased risk for aortic root dilatation. So management for patients that are given a clinical diagnosis of EDS type 1 include protective padding for the knees and elbows, chin protection during childhood, sutures need to be placed in 2 layers with no tension, and cardiology follow-up with at least a baseline echocardiogram. Ehlers-Danlos 1 isn't, to me, a really scary disease, but Ehlers-Danlos type 4 is a scary disease to me. This is the most severe form of Ehlers-Danlos syndrome. There are actually 11 different types of Ehlers-Danlos syndrome. I'm only going to ask you to know about 1 and 4. It's inherited in autosomal dominant fashion. But unlike Ehlers-Danlos 1 that I said, well, somewhere between 50 and 90% have a mutation of collagen 5A1 or 5A2, 97% of patients with type 4 Ehlers-Danlos have a mutation of collagen 3A1. Why that's kind of important is when I'm doing genetic testing, if I clinically think somebody has type 1 Ehlers-Danlos and they have negative genetic testing, they might still have that because it's a clinical diagnosis. With Ehlers-Danlos type 4, if there's suspicion that they may have Ehlers-Danlos type 4 and I have negative genetic testing, then I can feel fairly confident that they actually do not have it if I do not find the collagen 3A1 gene, because the vast majority of patients who have Ehlers-Danlos type 4 will have a mutation of this gene. So the clinical characteristics of Ehlers-Danlos type 4 or vascular type include joint hypermobility, but mild. Often they may not even have a positive Beighton score, easy bruising, a thin nose with small earlobes. Again, there's not a lot of clinical features, but the real risk is a risk of rupture of hollow organs, including the uterus during pregnancy and the bowel. The risk of uterine rupture is 5.2% during any pregnancy. And there's also a risk of aortic root dilatation and dissection. So the management for type 4 Ehlers-Danlos is to minimize the risk of injury, so no contact sports, because there's such a significant risk of aortic damage. Routine monitoring of heart and vascular tree with ultrasound and MRI, and aggressive management of hypertension. One other form of Ehlers-Danlos syndrome, which is actually the most common, is type 3, or we also call it benign hypermobility spectrum disorder. To date, there's no known gene, and it may be more of an autoimmune or rheumatologic thing. There's no increased risk of aortic root dilatation, as is seen in type 4. These patients have hypermobility of the joints and a lot of pain. They also have GI issues, and they have POTS, which is that when they stand up, they feel like they're going to faint and things like that. So this is the difficulty when 2 guys named Ehlers and Danlos named a bunch of things after themselves that are completely unrelated. So this is a clinical diagnosis, but to date, we've sequenced the entire human genome, and we have not identified a gene for this, and it's far more common than the first 2 forms of Ehlers-Danlos I just told you about. So the next important connective tissue disorder I want to talk about is Marfan syndrome. Marfan syndrome is caused by a change in the gene that makes something called fibrillin. And this is a component of the extracellular matrix which gives elasticity to tissue. The fibrillin gene, or FBN1, is located on chromosome 15, and mutations of this gene are identified in over 95% of patients who fulfill the clinical diagnosis. I would just like to say when I first started doing genetics and seeing patients with Marfan syndrome, they used to say it's 80%, and I'm going to talk about another disorder that looks very much like Marfan syndrome, but at the time, the only gene we knew about was FBN1. And so now, as with Ehlers-Danlos type 4, if I think someone has Marfan syndrome and they do not have a mutation of the FBN1, the chance that they have Marfan syndrome actually decreases significantly. Marfan syndrome is inherited in autosomal dominant fashion. It occurs in about 1 in 10,000 individuals, but 60% were inherited from a parent, whereas 40% it was a new mutation in the egg or sperm that made that individual. So when making the diagnosis of Marfan syndrome, we use something called the Ghent criteria, and this is a clinical criteria. Sorry about that. Used to make this diagnosis. There are 3 components to the Ghent criteria: systemic features, ophthalmologic, and cardiovascular. A family history of molecular change in the FBN1 gene are also important in making this diagnosis. So systemic features, there's a point system, and if you have over 7 points, it fulfills the systemic criteria for Marfan syndrome. So having myopia, you get a point. Mitral valve prolapse, you get a point. Stretchy skin, you get a point. Spontaneous pneumothorax, you actually get 2 points. So if you're walking down the street, it's not like you got in a car accident or somebody shot you. You're walking down the street and all of a sudden you have this horrible chest pain and they find extra oxygen there or air in there and they have to put in a chest tube. So I'll usually say to the patient, have you ever had a chest tube? And if they don't know what it is, then I know they never had one. Either an incurving of the chest wall or an outgoing of the chest wall. So a pectus excavatum or a pectus carinatum. Excavatum's much, when it sucks in, is much more common. You get 1 point for that. And the pointing out or carinatum, you get 2 points. A wingspan greater than the height. So if I measure, if he puts his hand straight out, the wingspan from finger to finger, and I compare it to the height, the wingspan being greater than 5% of the height, is considered, you get a point for that. And again, a lot of people have a wingspan greater than their height. That makes for great basketball players. But it's just 1 point. Flat feet, again, a common thing. Scoliosis, you get 2 points. Steinberg thumb and wrist sign. The Steinberg thumb is when you put your thumb and it covers over the other side, and the wrist sign is when you can put your hand and have overlap with your pinky finger. You get a point for that. If you can do both of them, you get 3 points. If you can do one or the other, you get 1 for whichever one you do. And then facial features include a long face with a high arch palate, crowding of the teeth. One of the questions that I'll ask about crowding of the teeth is, did you need braces? And when you got braces, not counting your wisdom teeth, because everyone needs to get their wisdom teeth out, but did they have to remove teeth? So those are systemic features, and you need 7 points. So you add up all these points and you see how many you get. Major criteria for the cardiovascular is aortic root dilatation or dissection. So it gets enlarged and then it rips. Ophthalmologic, we talked about myopia, which is a very minor feature. If I worried about everybody with myopia, I'd basically worry about everybody. But a major criteria is a dislocation of the lens, and when it's an upward dislocation of the lens. When we were talking about homocystinuria, they have a downward dislocation of the lens, but in Marfan's, it goes up. So, diagnosis without a family history of Marfan syndrome. As is the case with 40% of patients, you need 2 systems. So you either need an enlargement of the aorta and a dislocation of the lens, an enlargement of the aorta and a mutation of the fibrillin gene, an enlargement of the aorta or 7 points of the systemic features, or ectopia lentis and a fibrillin mutation. In the presence of family history, now you only need one thing because you already have family history. So you either need dislocation of the lens, 7 points of systemic features, or an aortic root with a Z-score over 20, over 2, over the age of 20, or over 3, under the age of 20. And the other one should actually be a fibrillin mutation. So if a father or mother had Marfan syndrome and I had a newborn, it would be very difficult for me to make this clinical diagnosis. So I would, if one of the parents had a fibrillin gene mutation, I would just test the baby for that. The next disorder I want to talk about is Loeys-Dietz. And Loeys-Dietz was described in 2005. And many of the clinical characteristics are very similar to Marfan syndrome. The risk of aortic rupture, however, is much higher than Marfan syndrome. And in fact, I'm always like, oh yay, you have Marfan syndrome, because this is a much scarier disorder. In addition, like in Marfan syndrome, the aorta gets a little bit bigger, a little bit bigger, a little bit bigger, then it rips. In Loeys-Dietz, it can go from normal to ripping like in a month. Loeys-Dietz is inherited in autosomal dominant fashion. It's caused by a mutation of one of 3 genes, TGFBR1, TGFBR2, or SMAD3. And these genes all play a role in the signaling pathway in the TGF-beta pathway, which is important in the cell during growth and development. And this pathway also regulates the formation of the extracellular matrix, and it's intricate in the proteins and how they are placed to give tissue strength and repair. So clinical features of Loeys-Dietz include widely spaced eyes or hypertelorism. They can have a pectus deformity of the chest wall. Gee, that sounds like Marfan. Scoliosis. I want to show you, see the back here how this is lower than this one. The scapula is a little bit lower. That's actually a sign of Marfan syndrome. That's when we're looking at the spine and then we have them bend over and one side looks a little higher than the other. But this, when somebody's standing, is a sign of scoliosis. Joint laxity, long fingers and toes. You can see how long this kid's toes are. Bifid uvula or a cleft palate. So here's usually you just have one little thing hanging. This kid has 2. So that's a bifid uvula or a cleft palate. Velvety, translucent skin with easy bruising, another common feature of connective tissue disorder. But the scary stuff is there's risk for cerebral, thoracic, abdominal aortic aneurysms and dissections, and the arteries are tortuous. There's also a risk of uterine rupture during pregnancy. So this disorder, to me, the scariest connective tissue disorders are Ehlers-Danlos type 4 and Loeys-Dietz. I know a lot of 70-year-olds that have Marfan syndrome. I don't know a lot of 70-year-olds with Loeys-Dietz. So management is frequent echocardiograms and very close monitoring with cardiology. So in conclusion, because of the overlap between Marfan, Loeys-Dietz, and EDS type 4, genetic testing is actually recommended. And when we do genetic testing, we actually do a panel of a lot of these genes at the same time. But the purpose of this presentation is just to talk about the clinical presentation of these different disorders.